So hello everybody. Welcome to the RSV WHO RSV Roadshow series. I'm Ruth Karen. I will be your host for today. Um, I don't think that I have control of the slides, so I don't believe so. So I think Melissa, I believe you are going to have to take control and advance the slides for us today. Could we go to the next slide?
Yes.
So this roadshow is based on the RSV Roadshow, a communications toolkit, and as many of you already know, there are seven web events that have been developed in association with this toolkit. We're targeting policymakers, decision leaders, immunization and antenatal care communities in low and middle income countries. And the goal is to increase awareness of RSV disease, prevention options, and implementation strategies. The slides that you see today and that you see in all of these series will be available along with speaker notes at the website shown below. Next slide, please. This is our third web event, and it's entitled RSV Prevention Approaches and Products for Protecting Infants. Next, please. So please, we are really looking forward to your questions at the end of the presentation and the reflection. Please don't submit them in the regular meeting chat. At the top, there is a button at the top of your screen that says Q&A, as you can see in this diagram. I'll be monitoring that Q&A and we'll summarize some of your questions to ask Professor Zara and Dr. Jalango. Next, please. So a little bit about me, you can see here. I'm a pediatrician trained in infectious diseases. I'm a professor in the Department of International Health at the Bloomberg School of Public Health at Johns Hopkins University. And I've been working on RSV epidemiology and RSV vaccines for a few decades now. Next slide, please. I'm thrilled to welcome also to give our presentation today is Professor Czar from the University of Cape Town, who has a very strong, she's a pediatric pulmonologist and has a strong clinical translational research program focused on childhood illnesses in Africa and globally, pneumonia, RSV, and developmental origins of lung health. Next, please. And our discussant today is Dr. Rose Jalango, who is the head of national vaccines, the National Vaccines and Immunization Program within the Ministry of Health in Kenya. Next, please. We're going to move quickly through our introductions because we have a lot to talk about today. What we'll do is Professor Czar will give a presentation, Dr. Jalango will give a reflection, and then we'll be really happy to take your questions. So over to you, Professor Czar.
Thank you so much, Ruth, and really thank you for the opportunity to present here today at this very exciting time for RSV prevention in infants and young children, where really for the first time we are poised to prevent this illness. My talk today is going to focus on the two approaches that have been approved for use in infants and young children, RSV maternal immunization. We'll talk about how vaccination in pregnancy works and discuss the new product information and evidence, and then long-acting monoclonal antibodies against RSV. We'll discuss how these antibodies protect infants against severe disease and also delve a bit into the new product information and evidence. Sorry, I also don't have control. So So just to remind you that RSV is a major cause of severe respiratory disease and hospitalization in young children. Many of you will be familiar with these figures, almost 33 million episodes of lower respiratory tract infection annually, around 10% of hospitalizations, and over 100,000 deaths due to RSV. And importantly, the severity of disease and majority of deaths are concentrated in low middle income countries and are concentrated in infants under 6 months of age, where almost 50% of deaths occur. And this is really important in terms of prevention because these preventive products target infants in their first month of life. And so we have the opportunity now to prevent much of these deaths and much of these hospitalizations and disease, as I hope to show you in the next slide. Next slide, please. Melissa, can you advance the slide, please? Right. So for a long time, scientists have known that a vaccine against RSV should target the F or fusion protein. And this is the protein on the virus that fuses to cells and enables the virus to invade cells and cause disease. The challenge was that this RSV F protein was very unstable and underwent dramatic structural changes from a pre to a post-fusion state after fusion. But the breakthrough came in around 2010. Can we see the next slide, please? Where scientists were able to stabilize the F protein in a pre-fusion state, shown here on the left-hand side. And you can see how different the pre-F conformation looks compared to the post-form. And you can see also that these are neutralizing sites displayed on pre-F. You can see that the pre-F version of the fusion protein displays more and better neutralizing sites than the post-F version. And so vaccines and the long-acting monoclonal antibody and the maternal vaccine are targeted against the pre-F portion of the protein. Next slide, please. Now, the best way to protect infants from RSV disease is by giving them passive immunization early in life. So this is giving them antibodies that are able to fight RSV infection. And these new RSV prevention products do this in one of two ways using the pre-F technology. Maternal vaccine given during pregnancy induces antibodies in the mom, which are then transferred to the baby through the placenta and protect the baby through those vulnerable first months, whereas a long-acting monoclonal antibody is given directly to the infant at birth or shortly thereafter and protects the infants against RSV by providing these preformed antibodies to RSV. And these products are now licensed in many countries and have just been recommended for global use by the WHO. Some of you will know that the Strategic Advisory Group of experts of the WHO recommended passive immunization, both these products, about 2 weeks ago at the recent WHO meeting. Next slide, please. So let's turn to RSV maternal immunization and discuss a little bit more how vaccination works and the details of the product information. Next slide, please. Now, for a long time, vaccines have been given in pregnancy. Many of you who work in the field will know that tetanus toxoid or tetanus diphtheria vaccines and even pertussis vaccines have been given to pregnant women as a way of protecting their vulnerable infants. And how these work is they induce pregnant women to produce antibodies. So here, if no vaccination occurs, in the top diagram, you see mothers have some antibodies already because they've either received vaccination in the past or had the infection. So they've got some levels of antibodies which are transferred via the placenta to their infants. But you can see if a mother is immunized, the number of antibodies is bumped up considerably. And so the transfer to her infant is much increased, providing much better protection and protection for a longer period of time. And this is the basis for immunizing pregnant women, in this case against RSV. Next slide, please. So the vaccine that has been approved for use is a pre-F RSV maternal vaccine. And I want to show you the results from the pivotal phase 3 clinical study called Matisse, which was done in around 7,420 pregnant participants. They received the vaccine between 24 and 36 weeks of gestation across 18 countries and many study sites. And this vaccine has been developed by Pfizer. Let's turn first to the efficacy results of this pivotal trial. And so, thank you, that's fine, the next slide. And so you can see first efficacy through 90 days and then through 6 months, through 180 days for different RSV endpoints. The first row is for severe medically attended RSV, lower respiratory tract infection. And you can see efficacy here of around 82% at 90 days and 70% at 180 days. And if one looks at less severe disease, just medically attended RSV, lower respiratory tract infection, you can see efficacy through 90 days of close to 58% and around 49% at 6 months. And so importantly, the efficacy remained high through the first 6 months after birth, the critical time when infants are most at risk for severe RSV disease. And in addition, efficacy occurred from day one of life, with incremental efficacy through the 6 months. So great news, protection against RSV from day one, RSV disease, that was sustained through 6 months of life. Next slide, please. Next, okay. In terms of safety, in general, safety was similar. These mothers were randomized 1-to-1 to receive either the vaccine or placebo. And there was no difference in adverse events amongst mothers who got vaccine or placebo. In general, safety events were well balanced between babies who were born to mothers who got vaccine compared to babies who were born to mothers who got placebo. However, there was a numerical imbalance amongst babies for preterm birth, as well as for low birth weight. And you see here, amongst babies born preterm, 5.7% of those born preterm were in the babies born to mothers who were vaccinated, the blue bar, compared to 4.7% in the placebo group. And if you look at low birth weight amongst amongst babies whose mothers were vaccinated, 5.1% born low birth weight and 4.3% born low birth weight if their mother had received a placebo. So these differences drop slightly in terms of low birth weight. A few points to make about prematurity and also low birth weight. Firstly, gestational age in this trial was largely estimated based on first or second trimester ultrasound. And in most low middle income countries, women in fact had an ultrasound during the second trimester of pregnancy, which we know can misclassify gestational age by 2 weeks and tends to underestimate gestational age. That's the first point. Secondly, the imbalance in preterm births was observed in 2 middle-income countries, South Africa and Argentina primarily. But there was no temporal relationship between the timing of vaccine and preterm births. More than 60% occurred after 30 days of giving vaccine, and almost all preterm births were late preterm births. And the preterm births did not translate to an increase in mortality. In fact, there was only 1 death from prematurity in the group of infants whose mothers had received vaccine. And this represented fewer infant deaths in the vaccinated arm compared to placebo. And people have evaluated this data very, very carefully. Multiple regulators, modeling studies, and most recently WHO SAGE confirmed that the benefit of vaccination outweighs potential risk of prematurity. But of course, post-licensure safety surveillance, ongoing monitoring of safety and effectiveness will be done. Next slide, please. The WHO SAGE recommendation in terms of maternal vaccine is specifically shown here. WHO SAGE recommended that all countries introduce passive immunization for the prevention of severe RSV disease in young infants. So this is either maternal vaccine or a long-acting monoclonal antibody. But for countries deciding to use the maternal vaccine, SAGE recommended a single dose given in the third trimester of pregnancy, which is as defined in the local context. It's usually around 28 weeks of gestation, but it could be earlier in some places. There is no upper gestational age limit for vaccination, except vaccination should not be given during active labor, and it can be given concomitantly with other vaccines in pregnancy. These are the specific WHO recommendations from 2 weeks ago. And as a result, this vaccine has been quite widely recommended, not only by WHO, but by PAHO and other European countries, as well as in the United States, with several high and upper middle income countries following suit. Vaccination should be given during defined gestational age windows to optimize protection for the infant. As indicated, WHO have recommended a 28-week and up gestational age window. Some countries have chosen to implement lower gestational ages, so from 24 weeks up, which you'll remember was the inclusion for the trial. And some have had an even more restricted gestational age window from 32 weeks and up. But overall, the global WHO recommendation is third trimester of pregnancy. The issue of whether the vaccine should be given seasonally or year-round will depend on the context and the countries. In general, a year-round approach is preferable for programmatic reasons, and especially in tropical and subtropical regions where RSV circulates for most of the year. But where countries have a clear seasonality and where the programmatic capacity exists, a seasonal approach could be considered. But obviously vaccination would have to start several months before the RSV season. And I think this may be quite challenging in terms of a maternal vaccination program. As I mentioned, it's a single dose that can be given with other maternal vaccines. It's given intramuscularly, and it's currently available as a single dose vial, but a multi-dose vial presentation is under development, funded by the Gates Foundation. And this will, with immunobridging studies currently being done. And the vaccine is subject to the standard cold chain. Next slide, please. Turning now to long-acting monoclonal antibodies, let's look at how these protect and also delve into some of the new product information and evidence. Next slide, please. So again, monoclonal antibodies have been used for various diseases for a very long time. They are manufactured antibodies that can kill a virus or other pathogen. And of course, they're antibody protection, so they protect immediately. Passive immunity, they don't require infants to produce their own antibodies. Many of you will be familiar with palivizumab, which is a short-acting RSV monoclonal antibody that's been licensed since 1998. And that has been used, has to be given as an intramuscular dose, given monthly through the RSV season, so up to 5 doses given through the RSV season. It's very effective for preventing severe RSV, but has its use limited to high-risk infants and toddlers because of the cost and the need for repeated intramuscular injection. Now we have new long-acting monoclonal RSV antibodies, and these differ from palivizumab in that they provide long-acting protection. So they provide protection for the duration of the RSV season and do not require repeated dosing. It's a single dose that can be given at birth, or prior or during the first RSV season, and they can also be used in high-risk children. So, for example, children with underlying congenital heart disease, chronic lung disease, who are at risk for severe RSV as they get older, even in their second RSV season. And there are two products. The one that I will discuss predominantly is lecivimab, because this has been licensed since 2023, and WHO has now recommended this. And the second product I will briefly touch on is clesrovimab, which is in late phase evaluation and for which the phase 2b/3 results were recently, a week ago or so, presented, and also will hopefully be available on the horizon in the future. Next slide, please. So obviously, to deliver an effective program for long-acting monoclonal antibody to protect all infants and children, and what I should have prefaced this with is that while we are aware of high-risk children being at risk for severe RSV disease, in fact, the major burden of hospitalization and of death occur in full-term healthy infants under 6 months of age. So the strategy has to be to protect all infants, the birth cohort born through that period of time for their first RSV season. And here, what I'm showing you is BCG coverage globally for 2022. You'll see very high coverage in Southeast Asia, the shaded blue, deep blue, and also areas of Africa and Latin America that also have very high coverage of more than 90%. And you'll see overall, there are also areas that have coverage of 80 to 89% in Africa. But overall, even in areas where there's not that great coverage, the coverage tends to be between 50 and 79%. So I think we need to acknowledge that BCG is a very widely used vaccine with actually very good coverage globally, and that this could be leveraged for a program that would administer a birth dose of a long-acting monoclonal. In addition, if a birth dose is not given, and for babies born out of health facilities, for example, the first EPI vaccination is usually given at around 6 weeks. And that also has high coverage globally, DPT and so on. And that, again, could be an opportunity to provide an early dose of a long-acting monoclonal antibody against RSV. Next slide, please. So let me show you the efficacy results. I'm going to primarily show you the results from two studies, the phase 2b study, which enrolled preterm infants, so infants enrolled at 29 to 35 weeks of gestational age, around 1,400 participants across 23 countries. And then the phase 3 study, MELODY, which enrolled term and late preterm infants born after 35 weeks of gestational age, around 3,000 participants. Similarly, high spread, 31 countries enrolled. Just to indicate that the initial phase 2 study used a 50 milligram dose, a single dose of 50 milligrams. And what was realized in that study, that is for infants over 5 kilograms, the 50 milligram dose was inadequate, and 100 milligram dose was needed. So the pooled results from these two studies, which I'm going to show you on the next slide, are pooled efficacy of infants who received the correct dose. So those under 5 kilograms receiving 50 milligrams, and those over 100 milligrams. And here you can see high clinical efficacy against different RSV endpoints through 150 days from administration of the dose. And starting with medically attended lower respiratory tract infection, you see a pooled efficacy of around 79%, and similar efficacy for hospitalized RSV disease or severe hospitalized disease. And in addition, there was also a reduction in all-cause hospitalization for respiratory illness, around 44% reduction, 35% fewer medically attended lower respiratory tract infections of all cause. And of course, this translates into reduction in antibiotic prescribing around 24%, which in the area of antibiotic resistance is also a really important outcome. A further trial, Harmony, which was a pragmatic clinical trial in real-world setting in the UK, Germany, and France, around 8,000 infants randomized either to receive nirsevimab or usual care, which didn't include nirsevimab, again showed high efficacy against RSV hospitalization, 83%, and around 58% efficacy against all-cause lower respiratory tract infection. And across these trials, there were no safety concerns at all. Next slide, please. And there's now a lot of accumulating effectiveness data that is coming from high-income countries. This is a summary of some of that data. You can see in red the effectiveness. So these are children who received nirsevimab or not, and the effectiveness in terms of RSV-related hospitalization or RSV-related intensive care unit admission has been calculated. You see effectiveness for RSV-related hospitalization varying from sort of 81% all the way through to 98% in these different areas, and similarly very high effectiveness for intensive care hospitalization. Next slide, please. And this is effectiveness data from Galicia, Spain, where a universal campaign was instituted to give all eligible children nirsevimab during the season. So children who were born during the infants who were born during the RSV season, or young infants born just before the RSV season, or high-risk infants going into their second RSV season, all received nirsevimab with very high coverage, over 90%. The program has a lot of lessons for all of us, amazing implementation, and look at these results. Really wonderful reduction in severe RSV, lower respiratory tract infection requiring oxygen, in hospitalization, 82%, and in all-cause lower respiratory tract hospitalization or all-cause hospitalization of 66 to 69%. So clearly corroborating the other effectiveness data that has been coming, and also the trial data. And the trial data was accumulated during COVID, so there were fewer admissions for RSV lower respiratory tract infection and for all-cause lower respiratory tract infection. But you see here, post-COVID, these results are really impressive. Next slide, please. And this is also very exciting data of another long-acting RSV monoclonal antibody, clesrovimab. This, similar to the other monoclonal, also provides sustained protection. It binds to site 4 on the RSV pre-F area. And these are the results of the phase 2b/3 efficacy that were presented last week at the World Vaccine Congress and also at ID Week. And what you can see here are efficacy for different endpoints through either 150 days in the middle column or through 6 months, 180 days in the last column. And if you look at the bottom, if you just turn to acute respiratory infection, so that's upper respiratory tract infection, very mild illness, you see an efficacy of around 52%. And as the degree of illness increases with increasing severity, 1 or 2 indicators of severity, hospitalization or severe medically attended lower respiratory tract infection, you can see that the efficacy increases all the way through to around 92% efficacy. And you'll also see very similar efficacy through 150 days as well as through 180 days. And clesrovimab is also given as a single shot. It's a single dose, 105 milligrams. And 1 dose here protected against mild, moderate, and severe RSV disease through 5 months with enduring efficacy through 6 months. So we will hopefully have another monoclonal antibody available in an armamentarium against severe RSV disease in infants. Next slide, please. So WHO SAGE recommendations in terms of long-acting RSV monoclonal antibodies, again, it's part of the strategy to introduce passive immunization for prevention of severe RSV. And the WHO recommendations are here for countries deciding to use a long-acting monoclonal. A single birth dose should be given to all infants born in the RSV season, or if a year-round approach is being considered. And if it cannot be given at birth, it could be given at the earliest opportunity thereafter, for example, in one of the EPI vaccination visits or prior to the RSV season. And SAGE did note the limited availability and current high cost of the current monoclonal antibody, which and the concern that this could impact on global access and equity. Next slide, please. So to summarize the nirsevimab data, it's been recommended by WHO as well as by PAHO. It's received regulatory approvals in the European Union, the United States, and with several other high and upper middle income countries as well. Where the question of seasonal immunization versus year-round immunization again depends on RSV seasonality and programs. Where RSV circulation is year-round, then a year-round immunization is preferred with a dose given at birth or shortly after birth. But where RSV seasonality is clear, a seasonal approach may be more appropriate, with administration during the RSV season or just before the RSV season, 1 to 2 months before for babies born before, as well as possibly administration for children at high risk of severe RSV disease in their second year, seeing their second year of RSV. Seasonal approach may be cost effective because you're likely to use the monoclonal for fewer months during the year in countries where there's clear seasonality. Just to recap on the product, it's a single dose. It can be given with other infant vaccinations. It's given as an intramuscular injection. It requires a standard cold chain, and there are two doses, 50 milligrams to infants under 5 kilograms, 100 milligrams to infants over 5 kilograms. And I should add that in, for example, the Galicia effectiveness study that I showed you, when it was given to high-risk children, so infants going into their second season, it was given as a 200 milligram dose, since they are older with bigger weight. Next slide, please. So what are the additional considerations in deciding these approaches? So these are the general considerations that WHO SAGE has made across both products. The decision of which product to introduce or whether to introduce both, for example, must consider cost, financing, supply, anticipated coverage, and feasibility of implementation within the existing health system and programs, acceptability to women or to infants, and the availability to administer either product. Both products can be co-administered with vaccines given at the same time. For both, it is important to have post-marketing surveillance. And the issue of seasonality versus year-round immunization, I think I've spoken to already. In general, year-round immunization is preferable in tropical, subtropical locations where there isn't a seasonal pattern to RSV circulation, but where there is clear seasonal circulation, and fortunately, the seasonality that disappeared in COVID has now returned in most places. Seasonal immunization may be considered depending on the program, cost, and feasibility. Next slide, please. And here you see where these products have been authorized. The blue shaded area indicates both products authorized to protect infants. This is around 39 countries. This is slightly out of date, it's August 2024, but I think still pretty good. And then the green areas on the Sivimab only, and the red areas are RSV-free maternal vaccine only. And you'll see that, you know, it's quite impressive for products that have only recently been developed and authorized, you know, around 2023. We see quite a rapid uptake, but I think what is glaring, and which all of you will no doubt be struck by, is the total absence of authorization in Africa, in areas of Southeast Asia, um, where, in fact, you know, these low middle income countries are where the biggest burden of severe disease occurs, where the biggest burden of mortality occurs, and also where access to care is the most limited. And we know in these areas, for example, that there are almost 4 times as many deaths from RSV occurring outside a health facility as occur inside a health facility. So the urgency to get these products out to the children who are in most need of this, and where the impact on infant mortality, on child health, and in reducing hospitalization may be the most profound, is really critical. Reducing hospitalization for RSV also, of course, has other knock-on benefits in terms of freeing health resources that are available for other illnesses, for other conditions. We know many hospitals in these areas cannot deal with the burden of illness that is required for infants and children. And so, as some of you who work in high-income countries will know, hospitals have been emptied of RSV, lower respiratory tract infection, in areas where there's been high coverage with these products. And not only that, but there have been reductions in all-cause hospitalizations for pneumonia and lower respiratory tract infection. So potentially freeing up a lot more resources for other illnesses. I also don't need to add the cost of these hospitalizations, the financial cost for families, devastating in low middle income countries. So again, another reason for these to be rapidly implemented in these areas. Next slide, please. So what would it take to strengthen global access? And this is highly dependent on support from Gavi, the Vaccine Alliance. Many of you will know that Gavi is an international organization created to improve access to new and underused vaccines for children in low middle income countries. And currently there are 54 countries eligible for Gavi support. Gavi actually approved RSV prevention in infants as part of its vaccine investment strategy through 2025. And hopefully will renew support for this through 2030 if the 5 criteria listed there in the slide are met. So there has to be availability of the licensed product, there has to be WHO pre-qualification, there has to be a SAGE recommendation, which, as I've told you, we now have. There has to be a cost within a predicted range, and Gavi has to have available funding to support this. Next slide, please. And so here you can see an anticipated timeline of RSV immunization product availability for Gavi eligible countries. And the dotted green line, a vertical line, is where we are now, with fortunately a WHO's SAGE policy recommendation for both maternal vaccine and for long-acting monoclonal antibodies. And so you see, going forward, what is required for the maternal vaccine to be rolled out in Gavi eligible countries will be WHO pre-qualification of the single dose vial, and then as well as for the multi-dose vial, which as I said, is currently under development with bridging studies currently being done, and hopefully the multi-dose vial translates into a lower cost. And then UNICEF tender and Gavi co-financing for rollout. For the monoclonal antibody, the product presentation would have to be suitable for Gavi eligible countries, and of course, a price commitment made, and then as well, a UNICEF tender and Gavi co-financing. And so you can see the projected timeline for rollout of either of these products would be 2026, anticipated for the maternal vaccine, and 2027 for the long-acting monoclonal antibody. I mean, I would just like to make a plea that if there are policymakers on this call, or if there are people in positions who are making these decisions, that this be fast-tracked as fast as possible. We urgently need these products rolled out in low middle income countries. We saw in COVID very rapid uptake of immunization, new immunizations. And I think, you know, we need to move much faster than we have in the past. For example, with pneumococcal conjugate vaccine, we have an incredible opportunity now to really impact, reduce childhood pneumonia, reduce hospitalizations, reduce severity of disease, reduce mortality. And we have the tools to do this, but we need to get them out to the children who need it the most. Next slide, please. So let me leave you with some final thoughts. We have these new incredible RSV immunization tools after many years of work that really can dramatically improve infant and child health globally. Now is the time to raise awareness and support global, regional, and country decision-making around introducing these products for RSV prevention in infants and young children, and for preparing to implement. We do have structures that would facilitate implementation. We do have maternal vaccine programs already. We do have, as I said, BCG and EPI programs that are strong in many low middle income countries, and I believe we can leverage these. The new tools for preventing RSV in early life are either a maternal vaccine or a long-acting monoclonal antibody given to infants. They offer an overdue chance to address millions of hospitalizations, thousands of deaths, huge strain on healthcare systems, huge economic impact on families, and potentially set children on a path of health for life as opposed to a path of impaired health. And adding one of these RSV prevention interventions to the immunization toolkit could keep children out of the hospital, save many young lives, reduce antibiotic prescribing, reduce all-cause lower respiratory tract infection, and free up resources for many other health priorities. Thank you.
So thank you very, very much, Professor Czar, for that presentation. I'd like to actually now call on Dr. Rose Jalongo. I think we'll hold off on that. Maybe could we go back to the last slide, the thank you slide? Thanks, Melissa. Let's just go back to that for the moment. I would just like to call on Dr. Jalongo to give some of her reflections. And when she's finished, we're going to open this up to questions. So I don't see any questions in the Q&A function yet. So I'd like to encourage you to post your questions there, and then we'll be able to ask both Heather and Rose to answer those as we conclude the program. So Dr. Jalongo, over to you, please.
Thank you, Ruth. Good morning, good afternoon, good evening, colleagues. I'm going to give my reflections concerning the recent additional intervention on RSV given by the SAGE in September 2024. So I'll build on the presentations. I'll make reference to Heather's presentations on how we intend to introduce RSV vaccine into our routine immunization programs. So as a comment, from her timeline slide, we could see that their vaccine has actually been approved in September 2024, but we are going to have a time lag of 2 to 3 years before the vaccine is actually available in the low middle income countries, where pneumonia is one of the killer diseases in children, especially under 5. So again, this is quite unfortunate because we do have an intervention, but again, there are a lot of things that delay the introduction of vaccines, again, introduction of vaccines in the low middle income countries. So what I'd like to reflect on is number one, now that we have a WHO SAGE recommendation on RSV vaccine introduction, we have the vaccine and also the monoclonal antibody that is available in the market. So what happens in countries, for example, if Kenya is interested in introducing RSV vaccine, as a policymaker, one of the key issues that we look at is that, one, we are a Gavi eligible country. So Gavi eligible countries depend on Gavi to introduce new vaccines because they are introduced. We get a new vaccine introduction grants from Gavi, and this makes the vaccine quite available. So again, in terms of the process of making the vaccines available through Gavi would be one of the key incentives for me as a policymaker in terms of introducing RSV into the routine program. Secondly, we do have our NITAGs. So these are the bodies that make decisions in terms of whether a vaccine needs to be introduced or not. So our NITAGs look at a framework of recommendation in terms of when they're looking at an intervention. So for example, for RSV, we do know the burden of disease. We do know the cost of hospitalization, the cost effectiveness, perhaps not from our setup, but again, they're going to review local data in order to make that decision. But some of the other things they look at is, so if the cost of introduction is going to be covered by Gavi, they look at the impact it's going to have in the country in terms of mortality reduction. Then we have to look at the programmatic feasibility of introducing the vaccine or the monoclonal antibody. So in our context, we do have already maternal vaccines that have been rolled out. We've been giving tetanus, diphtheria for the last 40 years in our immunization program. And then BCG is one of those vaccines that are given at birth. So when it comes to introduction of new interventions that can be co-administered with BCG and also can be given during pregnancy, especially as a co-administration, that is something the policymakers would consider. The coverage for BCG is quite high in Kenya, more than 80%. So that would mean that if an intervention is introduced alongside BCG or oral polio, automatically we are going to have high coverage of that intervention. The beauty about these products, as per the presentation, is that they follow, they are stored in the standard cold chain, what we need, and any new vaccine being introduced need not duplicate or create new systems for introduction. We leverage on EPI infrastructure to either introduce new maternal vaccines or infant vaccines to our programs. In terms of service delivery, the same healthcare workers that are administering other products are going to be used to give these vaccines to the eligible population. So what can we be doing now, even as in the meantime, even as we wait for those products to be locally available? So number one, Gavi has to hasten the process of ensuring that Gavi eligible countries can now access the vaccine to support introduction of new vaccines in the countries. Meanwhile, on the parallel, the regulatory, national regulatory programs need now to discuss how these vaccines, apart from being licensed at a global level, how can they be licensed in countries in preparation for the introduction? The third thing is that NITAGs can start having the discussions of what if RSV is introduced now? Are we prepared? Two, do we need an RSV vaccine in countries? So for instance, in Kenya, what we've done is that within our NITAG, we've established a standing committee called Maternal Immunization Working Group, such that any matters on maternal immunization are discussed as a standing agenda, including RSV. So we do have different bodies doing different studies on maternal immunization. So we have an opportunity to discuss way ahead of the introduction as we wait for feedback on whether the countries are Gavi eligible or not. So this, in terms of Gavi eligibility, this helps the countries prepare based on where they are in terms of Gavi, whether they are in accelerated or the initial self-financing. It helps to prepare ministries of health and also our national treasury on how much funds to allocate in terms of preparing for the vaccine. And finally, even as we prepare for the vaccine, community engagement and creating awareness about RSV as a potential intervention that is either going to be introduced in children or pregnant mothers as an additional tool to reduce the impact, to reduce the burden of pneumonia and also the impact of that in those populations. So community awareness, community engagement on what RSV is and the potential in terms of these are some of the products that we do expect in countries within the next 2 to 3 years. Thank you.
Thank you. Thank you so much. I think we really appreciate those real world reflections. I'm going to encourage people to post their questions. I haven't seen any yet, so I think I will lead off with some of my own questions. And I think maybe Rose will start with you, and I'm actually going to ask folks to post their questions in the chat, not in the chat, excuse me, in the Q&A rather than raising their hands, if that's possible, and then we'll provide those questions. So, I think I'm going to start off with you, Rose, and I wanted to touch on that question, that comment that you just made, which is around awareness. And I just wonder if you could reflect a little bit um, on where you think folks are in Kenya with awareness with respect to policymakers, healthcare providers, and families, parents. Where are we starting from as of today, do you think?
In terms of RSV awareness, I'd like to admit that it's not well known as other diseases, especially other respiratory tract infection illnesses. But where we are at, we've started having conversations, especially with the professional associations. We've started having conversations with the Kenya Pediatric Association because they see children in their various capacity where they work. So the first time we did have this conversation with them, we did realize that not many of them were aware of RSV in terms of even the diagnosis, how to check it out, and the treatment. But it was an opportunity for us to start engaging. So since these are professional associations, the other point of reference where we think we need to start engaging is when it comes to the schools that train either the nurses or the healthcare professionals. So once it's embedded within the curriculum, within the next 2 to 3 years, we are going to be having a breed of healthcare workers who are able to identify or have RSV at the back of their mind as one of the possible or potential causes of pneumonia in children. In terms of the healthcare workers at the lower levels, again, in terms of the current healthcare workers who are working in the different facilities, their awareness of RSV is quite low. So what we plan to do is that we want to include RSV as part of the package, and as part of information, education, communication materials that are produced by the Ministry of Health to bring up to speed the healthcare workers on matters of RSV. So there's still a lot of work that is needed in terms of creating awareness, one, amongst the healthcare professionals, creating awareness at the policy level, creating awareness at the community level, and also creating awareness in terms of people generally knowing what RSV is. This will make it very easy when the vaccine is being introduced. When someone can identify with the disease, they can also identify with the intervention that is meant to come alongside it. Thank you.
Okay, thank you. And I do now see some questions popping up in the Q&A. And one of them, I'll put some together and ask, and some for Heather. I was wondering if you commented a bit about countries that have introduced nirsevimab, Spain in particular, but there are other countries as well. I wonder if you could say something about countries that have introduced Abrysvo preferentially. I know there are a couple of countries that have done that. Could you comment?
Sure. Can you hear me? Sorry. Yeah.
Yes.
So if I could just follow up on what Rose was saying about advocacy and awareness, I also just want to highlight that I think it would be useful to create awareness around this being a vaccine against childhood pneumonia. You know, mothers don't understand pneumococcal disease. We've never advertised PCV as as a pneumococcal kind of, that the awareness has been around pneumonia prevention. And I think the same should hold true for RSV. Because it is the major cause of pneumonia, and also because the evidence is that these products impact on all cause pneumonia. And I think pneumonia is something that many mothers, many families understand across low middle income countries. That was just the one point I wanted to make. To respond to the question about where the maternal vaccine has been globally introduced, I think Argentina is a very good example. Since March 2024, 134,000 women vaccinated in that seasonal campaign, around 60% coverage for that for the birth cohort. So that is one place where we've seen high uptake and use of maternal vaccine, and this was in a gestational age, I think. 32 to 36 weeks. Other places, Luxembourg, the national program was started in August 24. France just started in September 2024. The United Kingdom, as was alluded to, the United States actually started a while ago, October 2023 to January 2024, with the second year of the vaccine started now. So sort of a seasonal approach. And then I think Uruguay is another country of note that started on August 2024. In terms of nirsevimab, I think, one country that stands out is Chile, which introduced universal nirsevimab. And the results of this were also presented at ID Week a few weeks ago. Incredible results. I mean, the hospitalization rates, the mortality rates, whichever outcome you look at, have plummeted substantially. Even in a place like Chile, which is really got excellent healthcare, and that, as far as I know, is the one country that has introduced universal nirsevimab.
Yeah, thank you. Thank you. And I think just to add on to that a little bit, that I know that the UK and Argentina are countries that have particularly introduced maternal immunization. Some countries like the US have introduced both. I know we don't have a lot of time. There are a number of questions. I'm going to maybe speak to some of those and just summarize. I think one question has to do with how long does immunity last for these products? And I think We know in general it is about 6 months. It will generally, in many countries, not all countries, take children through their first RSV season. So there could be an opportunity for active immunization for older infants and toddlers for their second season, and work is going on related to that. I know that there are questions regarding cost. And I think while we can't speak to the specifics of that, there are, I know, real efforts to make Abrisvo available at affordable Gavi prices. There have been nothing specific that I've heard of yet, but for clesrovimab, for that monoclonal antibody as well, a real desire to develop something that will have global availability. I know we're at the end of the hour and beyond, and we're losing people, so I'm sorry we can't get to all of the questions. Could we go to the next slide, please? Thank you, Melissa. And I wanted to thank everybody who attended, and I'm sorry that we couldn't get to all of the questions. We had a lot to talk about today. This was the third presentation. The next web event is on the economics of RSV prevention. That will be on December 4th. There's more information about that coming soon. And you can visit the Roadshow website to learn more about that. Next slide, please. So thank you all so much for attending. You'll be receiving an evaluation form by email. And just to also mention that there is an RSV chatbot that will be launched on November 12th, which is also World Pneumonia Day. And if you want a sneak preview, please go to the chatbot website that is listed on the slide. And thank you all so much for attending. Thank you.